From the previous discussion, all I would like to say, and everybody likes to say the last word, it is in the practice. You look at the practice of conventional nuclear medicine and the structural nuclear medicine, and they are now hybrid, and as my talk will demonstrate, there is the function that is the most important thing, and the structure comes in secondarily. But I am biased because I am a nuclear physician married to a radiologist. So hybrid is really the thing. Here what we are going to talk about today is dual tracer radionuclide imaging in hyperparathyroidism. The outline of the talk will be, I will briefly discuss the parathyroid anatomy, embryology, the parathyroid physiology, the clinical context of hyperparathyroidism, parathyroid gland imaging, the radiopharmaceutical, the scintigraphic techniques, but very, very briefly, and I'll try to stick to the time, and how to optimize the image and display spec, CT, thallium, and sesmidi imaging cases, and then I will come to the main topic of parathyroid thallium imaging, which used to be and then was discarded, has now has a re-advent, and then what is the tailored approach to radionuclide parathyroid imaging. Parathyroid anatomy, as we know, there are two pair of parathyroid glands, superior and inferior, 2 to 6 in number, 50 grams in weight, and they are mainly composed, and I want to underline this fact, of chief cells which are responsible for parathyroid hormone secretion, and a smaller number of oxyphil and transitional cells. The oxyphil cells are what are imaged by sesmidi, not the chief cells. So this is a very strong point to note at this point. The parathyroid embryology is important because of the ectopic location, the embryological origin of thyroid, parathyroid and thymus glands. The inferior parathyroid glands and the thymus develop from the pouch 3, and they go along with the thymus downwards, whereas the superior parathyroid glands develop from pouch 4. Therefore, the parathyroid ectopic glands, which could be 15 to 20% in number, range all the way from the angle of the jaw to the pericardium. And you can see there are multiple locations. They could be undescended, retropharyngeal, intrathyroidal, posterior superior mediastinal, anterior superior mediastinal, and true superior mediastinum. So these are the locations. Parathyroid physiology, parathyroid hormone is responsible for calcium homeostasis through 4 different mechanisms, through a direct action on the skeleton, stimulating the osteoblastic activity to promote calcium release from the bone, the facilitation of calcium absorption by the kidneys through an increased conversion of 25 hydroxy vitamin D to 125 hydroxy vitamin D, and increasing calcium absorption from the GIT and blocking reabsorption of phosphate in the proximal tubule, while promoting calcium reabsorption from the ascending limb of loop of Hindley. So symptoms of hyperparathyroidism, it was classically, it was known as a disease of bones, groins, and renal stones. However, in current days, because of the early diagnosis laboratory, we rarely meet patients with such classical symptoms. And the types of hyperparathyroidism primary, well, I was given this, okay, so primary, secondary, tertiary. Primary is mostly due to a single adenoma and 4-gland hyperplasia in 15% of the patients. So parathyroid hormones, adenomas are most chief cell adenomas, and hyperplasia are chief cell hyperplasia. So I said before, the current diagnosis of hyperparathyroidism is based early on due to early diagnosis of hypercalcemia, and which is known as the normal, borderline, or sporadic elevation in serum calcium, known as the eucalcemic or normocalcemic hyperparathyroidism. Now the for the last several years, until the advent of the invasive surgical techniques, parathyroid localization was deemed only feasible for the best localization test was said to be to localize. A good surgeon will take all of the glands, but now because we have non-invasive surgical techniques and intraoperative parathyroid hormone assays and intraoperative gamma probe localization of the culprit parathyroid lesion has revived the need for preoperative localization Here's a picture of a gamma probe, radio-guided minimally invasive surgery compared to bilateral neck exploration, minimally invasive approach. Here's a small incisions, less complications, can be performed under local anesthesia as an outpatient procedure. The structural imaging are ultrasound, CT and MRI. Radionuclide imaging is planar, subtraction imaging, SPECT CT, and now PET CT. The radiopharmaceutical, historically a cyanocobalamin, thallium-201, maybe tetraphosphamine, and selenobethunine was introduced in 1960s, poor biological and imaging characteristics. This was superseded by thallium technetium subtraction scanning in 1980s, and this was the first practical parathyroid imaging agent. Then when MIBI came in, it took it over. I will try to show the mitochondria-rich oxyphil cells are responsible for maybe retention and localization, because the washout tissue from the parathyroid glands is slower than that from the thyroid, but the sensitivity ranges widely. And that's why we used to have a dual subtraction scanning, we still have, whereas thallium, maybe tetraphosphamine can localize the thyroid and the parathyroid, with the thyroid being localized by technetium pertechnetate or I123 iodine, and you then subtract one from the other and you are left with the image of the parathyroid gland. Early cases, I'm very proud of that. This is the first case I performed at the Nuclear Medical Center in AFIP in Rawalpindi in long time ago in 1986, 3-year-old girl with primary hyperparathyroidism, parathyroidectomy failed, thallium scan, and then the technetium scan and the subtraction scan shows a parathyroid adenoma. Another case of which I did at that same time, ultrasound shows two nodules with the right thyroid lobe, and the thallium scan shows uptake in the upper right lobe, and the thyroid scan shows a hot nodule in the lower right lobe, and this is a subtraction scan shows the interest focus of activity in the upper right lobe. So here we have a case of a large thyroid adenoma as well as a parathyroid adenoma diagnosed that far back. So you can see how thallium was so very specific to this. I will not go into this. This is just the image optimization because the time limits, because inverse grayscale is better, and again by compressing the lower levels and expanding the values of higher pixels, giving you a better image as you can see here. And I prefer the red, blue and green, which actually extrathyroidal are in blue, thyroid is intermediate level, and hyperactive parathyroid is in red, and it's easy to do it if you have the workstation. The current cases, I will just show you this thing. This is a primary hyperparathyroidism, and you can see a parathyroid, left lower parathyroid adenoma here, which says MIBI, and this left lower parathyroid adenoma on the SPECT CT. And another case here, you have the pertechnetate, maybe planar, etc., and it shows something ectopic, possible ectopic parathyroid adenoma, which is very easily localized by a SPECT CT scan. Now, there are very many factors that affect this SBB uptake, including size, cell type, mitochondrial structure, metabolic, secretory activity of the cell cycle, and the expression of P glycoprotein, I think, is not that important. So in my early experience in patients with persistent biochemical hyperparathyroidism, primary or secondary, with a negative SBB scan, which was successfully localized accidentally by thallium-201, and I'll show you a couple of fake cases here. You have these planar images, and they are negative, but when you do maybe technetium subtraction scan, you see technetium, thallium technetium subtraction scan shows a right parathyroid adenoma in this case, and the false negative technetium SBB scan. And this patient was taken to the surgery, and they was successfully, we took out a right upper parathyroid adenoma. So it's a case of a maybe negative thallium positive parathyroid adenoma with no P glycoprotein expression. Another case, again, there was no adenoma seen, but it was seen on a subtraction scan here. So the results of this early planar cases encourage me to investigate patients with biochemical, both primary and secondary hyperparathyroidism. Well, I have to finish it. With SPECT CT scan with a follow-up thallium scan, and this is a study that was published in the Nuclear Medicine Communication, dual stage tracer radionuclide imaging in hyperparathyroidism to revisit thallium parathyroid scintigraphy. The aim of the study was to look at the possibility of an incremental diagnostic role of thallium parathyroid SPECT CT in patients with presumably false negative SPECT CT scan results. And there were 22 patients, 16 primary, 6 secondary, where SESBB scan was negative or inconclusive, or where additional lesions were suspected on structural imaging. And these are the imaging techniques. And here we have the planar images being negative, but when you do a technetium MIBI scan, you see a right-sided parathyroid adenoma, and a thallium scan again shows a right-sided parathyroid adenoma. So dual tracer MIBI and thallium thallus chloride avid right parathyroid adenoma. So here both the MIBI and the thallium were equally effective in localizing the adenoma. This is a patient with primary hyperparathyroidism. MIBI scan shows uptake in the smaller adenoma up there with the green arrow, whereas the thallium scan shows uptake in both the smaller adenoma as well as one in the lower one. So it's a double parathyroid adenoma. Only one was maybe avid, whereas both were thallium positive. Another case here with uptake in bilateral lower parathyroid glands, you can see on CEST MIBI, but when you do a thallium scan, you can see uptake in 4 parathyroid lesions here. So 4 gland parathyroid hyperplasia, 2 CEST MIBI avid glands, and 4 thallium avid glands. So here is a case where we have a technetium MIBI scan in a patient with secondary hyperparathyroidism, which is negative. However, when you do the thallium, you see a 3-gland parathyroid hyperplasia. So we come to the results of the study. Further imaging with thallium 201 SPECT CT showed 46.5% additional lesions in patients with hyperparathyroidism in primary caused by adenomatous or hyperplastic glands. Thallium 201 imaging showed 59% additional lesions, hyperparathyroid lesions, and patients with secondary hyperparathyroidism, 33% hyperplastic additional parathyroid lesions were seen. The reason I said, and I've said it earlier, it is because of the localization of thallium in the sheath cells, which are actually the main culprit factor, or is that. And because in the planar imaging was superseded by planar MIBI imaging, and because it's superior physical characteristic, thallium imaging was abandoned. But when you do a thallium SPECT CT, it can not only not provide equivalent physically and technically equivalent result, but because of the biological characteristics is superior. So these results of this pilot study strongly advocate a role of thallium parathyroid SPECT CT imaging in patients with primary and secondary hyperparathyroidism with the initial technetium MIBI scan is deemed to be false negative in the presence of biochemical hyperparathyroidism, and I'll stop it here.